Welcome to the Radiographics Podcast. I'm Wendy Gibbs. We have two more great articles to summarize this week. The first is from the most recent issue of Radiographics, the role of CTA in life and limb-threatening trauma. I found this one fascinating. There's so much that can be done these days to reassemble victims of trauma, and we play a vital role in getting this information to the surgeons in time. But we need to know what is available and what to look for. Then my article is from the archives, but is essential for all of us, recognizing implanted electronic stimulation devices, which are ubiquitous these days, as well as complications related to the device and MRI safety. Let's start with Dr. Frederick's article.
Roles of trauma CT and CTA in salvaging the threatened or mangled extremity. Kind of a gruesome topic, is it not? Which is exactly why it caught my eye and drew me in, and after reading it, I can say that it did not disappoint, as I learned a lot of new and interesting things. Extremity arterial injuries account for up to 50% of all arterial traumas. CTA is used liberally when a limb is in ischemic jeopardy or is a potential source of life-threatening hemorrhage. The radiologist plays a critical role in the rapid communication of findings related to vessel transection and occlusion. When functional salvage is feasible or urgent hemorrhage control is required, communication with trauma surgeon colleagues is augmented by an understanding of the unique surgical, endovascular, and hybrid approaches available for each anatomic region of the upper and lower extremities. Clinically relevant postoperative CT and CTA interpretations require a basic understanding of the natural history of severe extremity trauma and the first principles of damage control, definitive vascular intervention, and reconstructive surgery. CT and CTA are performed for surveillance after open primary repair, graft placement, and angiographic stent placement, also for planning staged reconstruction with myocutaneous flaps and bone grafts, as well as to evaluate complications after limb salvage or amputation. CTA reduces delays to extremity reperfusion and hemorrhage control. Historically, CTA has been a screening tool for patients without hard signs of hemorrhage or ischemia. Hard signs that have traditionally warranted immediate surgery or conventional angiography include external hemorrhage, expanding or pulsatile hematoma, bruit or thrill, pallor or cool extremity, and absence of a distal pulse or neurologic deficit such as loss of plantar sensation. When the blood pressure in an injured extremity is decreased compared to the other, it suggests flow-limiting extremity vascular injury and warrants triage to CTA. CTA is now used for surgical planning in patients with some degree of shock and evidence of hard signs, and is warranted for proximity injuries, which are penetrating wound paths in the vicinity of major extremity vessels. Extremity CTA facilitates accurate and reproducible detection and characterization of arterial injuries with remarkable accuracy. Clinically significant injury can be confidently excluded when an artery is well enhanced, with no mural or perivascular abnormalities. Important descriptors of injury include location and length, degree of stenosis, and level of reconstitution. Following penetrating trauma, wound tracts or ballistic fragments within 5 mm of a neurovascular bundle raise suspicion for vascular injury. The severity of arterial injury depends on the depth of mural involvement. CTA findings include active extravasation of contrast material, pseudoaneurysm, abrupt luminal narrowing, intimal irregularity or flaps, non-opacification, and AV fistulas. Active hemorrhage with lack of distal opacification is most consistent with complete transection, while continuous distal opacification suggests partial transection. Arterial occlusion, followed by pseudoaneurysm, is the most commonly reported injury. Dissections more often appear as semilunar luminal deformations and either eccentric stenosis or complete occlusions. Pseudoaneurysms are contained by adjacent soft tissue or adventitia and manifest as enhanced outpouchings from an adjacent artery with rounded margins, whereas active hemorrhage appears as an irregular contrast blush surrounded by hematoma or insinuating along disrupted fascia. AV fistulas appear as early venous enhancement. Veins may be engorged and a communicating channel is occasionally appreciated. Luminal narrowing is usually eccentric if it results from extrinsic compression by hematoma or bone fragments, non-occlusive thrombus, or dissection. Reactive vasospasm is typically smooth and concentric. Distinguishing between occlusion and severe spasm can be difficult in distal small arteries. The extremity is not considered to be threatened and can be safely observed and managed non-surgically if the arterial injuries are characterized by the following: small downstream protruding intimal flaps, pseudoaneurysms with minimal wall disruption that is less than approximately 5 millimeters in length or diameter, lack of transection, and intact inline distal flow with a continuous contrast column through the distal runoff. Progression of approximately 10% of initially minor proximal traumatic arterial lesions to sizes larger than 5 millimeters in length or diameter at follow-up CTA may result in thromboembolization, requiring distal cut-down and thrombectomy, in addition to primary lesion repair. The injury mechanism also plays a role in determining whether an extremity is threatened. Close diaphyseal long bone fractures are associated with a 0.1% risk of arterial injury. Injuries requiring greater scrutiny include compound fractures, especially those involving severe fracture displacement, segmentation, comminution, or a floating joint, in which displaced diaphyseal fractures, both proximal and distal to a joint, render it highly unstable. Crush injury, shotgun blasts, and high-velocity or close-range gunshot wounds pose the greatest risk of vascular injury and amputation. Timing a study to achieve adequate distal arterial opacification is challenging. Fixed delays, bolus tracking, and test injections can be used. Bolus tracking and test injections are considered to be more precise, although some advocate using a fixed delay of 20 to 30 seconds in young healthy patients with normal cardiac output. Up to 8% of extremity trauma CTA exams are non-diagnostic, frequently because of poor arterial opacification that results from early scan timing. Less commonly, venous opacification may interfere with interpretation if scanning is excessively delayed. Bolus timing and fixed delays can be adjusted as needed and the exam repeated by using a second contrast bolus. Although extremity CTA is typically performed in 2 phases for peripheral vascular disease, single arterial phase CTA is commonly acceptable for extremity trauma. Unlike conventional angiography, CTA offers the advantage of imaging both extremities simultaneously in a single acquisition. If only one leg is of interest, it still may be helpful to incorporate a wide field of view axial series of both lower extremities, in addition to cone down and multiplanar reconstructions of the injured extremity. This would help to distinguish vascular injury from poor contrast timing. Other pitfalls to consider include the loss of distal arterial enhancement in the setting of advanced compartment syndrome or spasm. Digital subtraction angiography performed with an intraarterial vasodilator such as piperavine may be necessary to distinguish spasm from injury. Let's talk about compartment syndrome, which is more common in young males who have more muscle mass and tighter compartments at baseline. It most commonly occurs after tibial shaft fractures, followed by distal radius fractures. While CTA is not formally used to determine the need for fasciotomy, CT findings of rhabdomyolysis, which includes focal or geographic areas of muscle hypoattenuation and enlarged edematous musculature, are suggestive of compartment syndrome. Peripherally enhancing intramuscular collections indicate progression to myonecrosis. What are some other roles that CTA plays in assessing the mangled extremity? CTA is sometimes used to plan anastomosis of myocutaneous free tissue transfers or pedicled fibrillar grafts. The latissimus dorsi muscle is a common donor site because of its long vascular pedicle and large bulk. The posterior tibial artery is a common recipient vessel for free myocutaneous flaps, and the perineal artery is a common recipient vessel for fibular grafts. A contralateral free vascularized fibular graft with a perineal artery pedicle provides optimal healing for large defects, those more than 5 to 8 centimeters, while cancellous grafts are used for smaller defects. Vascular graft thrombosis is a common and feared complication of limb salvage. Autogenous vein grafts become occluded as a result of infection or excessive anastomotic tension in 10 to 20% of patients. CTA may be performed to evaluate the patency or blowout of vascular grafts. Contrast-enhanced CT may reveal infection at the incision site, wound breakdown, myonecrosis, or osteomyelitis with deep infection at successive stages of reconstruction. Lastly, after amputation, CT scans obtained to evaluate stump complications should be scrutinized for any evidence of surgical dehiscence, ulceration, infection, postoperative hematoma, persistent bone fragments, heterotopic ossification, excessive scar formation, and/or vascular patency.
So interesting. And the authors of that win the prize for best article title. Mangled extremity. I love that. Okay, I'm delving into the recent archives for my article this week. I was on call and read an x-ray that had an electronic stimulation device that I didn't recognize. So when I went to search for more information online, as usual, I found a great radiographics article. This was from 2019, describing a number of electronic stimulation devices, what they look like, what they're for, complications we might see, and MRI safety. Electronic stimulation devices are implanted in various locations in the body to decrease pain, modulate nerve function, or stimulate various end organs. And there are more of these every day, can't even keep up. The majority of these devices have a common design theme that includes the following components: a pulse generator that houses the battery and control electronics, an insulated lead or wire that conveys signals to the last component, which is an electrode that contacts the end organ and senses and/or acts on that organ. The devices I'm most familiar with are deep brain stimulators and spinal stimulators. So let's start with DBS. DBS electrodes are inserted into various deep gray nuclei, most commonly to treat symptoms of movement disorders. The FDA approved thalamic DBS for treatment of essential tremor and Parkinson's disease a long time ago, 1997, and subthalamic nucleus and globus pallidus internus DBS for treatment of Parkinson's disease in 2003. Since then, they've been used for a number of additional disorders, including obsessive compulsive disorder, Tourette syndrome, medically resistant depression, epilepsy, obesity, headache, chronic pain, and dementia. DBS does not treat the underlying disease. Rather, it's used to control symptoms. This comes after failure of medications or other more conservative treatments. Imaging plays a role in DBS device implantation planning and performance, typically performed by the neurosurgeon. However, radiologists do perform an important role by identifying any abnormality along the proposed lead path, such as tumors like a meningioma, I have a great case of that, large perivascular spaces, foci of prior hemorrhage, such as in amyloid angiopathy, anything that may cause an unexpected result, complication, or failure. Electrode locations vary depending on the disease being treated and include the subthalamic nucleus, globus pallidus, ventral intermediate nucleus, and striate areas. CT, MRI, or both are performed with a head frame or with fiducial markers alone. A common strategy is to perform CT with fiducial markers and register it to MRI performed without markers, which is then used to identify specific targets. Data are fed into the surgical guidance system, which plans a trajectory on the basis of the patient data and data from standard atlases or models. With the help of MRI performed after the administration of contrast, an entry point and trajectory are chosen. Intraoperatively, microelectrode recording and/or microstimulation are also used to localize the electrode tip. Intraoperative MRI may be performed for real-time guidance, thus allowing for a non-awake procedure, immediate detection of complications, and a more accurate delineation of the anatomy following brain shift after dural opening, cerebrospinal fluid leakage, or subdural collections. Following the electrode implantation, the pulse generator is implanted in the upper chest and the leads are tunneled and connected. After a recovery period, the device is programmed such that the optimal electrode elements are used to accomplish the clinical goal with minimal side effects. Fluoroscopy or radiography is routinely used to confirm lead position during and after electrode insertion, and additional imaging is not routinely needed. However, if intraoperative MRI and routine post-op CT are performed, the exact electrode position can be confirmed, and immediate complications can be identified. On CT, the lead should be depicted entering the skull through burr holes and coursing toward the targeted structures. A small amount of pneumocephalus may be seen postoperatively, but there should not be a large amount. When unexpected clinical features manifest postoperatively, such as mental status change, seizure, or focal neurologic findings, performing further imaging, usually with CT, is indicated. Immediate complications following device implantation include hemorrhage or infarction. Hemorrhage may occur owing to a direct injury to an artery or vein, or venous infarct with resultant hemorrhage. Hemorrhage can be subdural, subarachnoid, or parenchymal. In a recent study, the hemorrhage rate was only about 1.4%. Although infection may affect the leads or electrodes, it more commonly involves the pulse generator in its pocket. Unilateral or bilateral edema occurs along the leads after insertion in approximately 3% of patients, 4 to 120 days after surgery. This was something in the article that I did not know and I actually have never seen. The cause is unknown, and edema may be asymptomatic or accompanied by headache or seizures. If there are no signs of infection, this process is self-limited and will resolve with treatment with steroids or supportive care in a week to a month. It's important to recognize this self-limited process so that the system is not removed needlessly. Delayed lead fracture may lead to system failure and is detectable on radiographs. One recent review of 249 patients showed that lead breakage was the second most common delayed complication, with a rate of almost 10%. The infection rate was reported at 12.5%. Here's another one. This I actually have never seen. Occipital nerve stimulation devices used in the treatment of severe occipital neuralgia or chronic migraine. Implantation of the device is performed in one stage or following a trial period. Subcutaneous electrodes are implanted over the occiput in the region of the greater and/or lesser occipital nerves using bone landmarks. Once the electrodes are placed, the leads are tunneled subcutaneously to a subcutaneous pulse generator. Fluoroscopy or radiography is performed following implantation to document electrode and component placement. On radiographs, the lead should be continuous and depicted trailing from the occiput down to the subcutaneous pulse generator, which may be placed in the chest, abdomen, or back. A subcutaneous loop is introduced in the wire at the occiput to produce slack in the system and prevent electrode displacement when the neck is hyperflexed. Vagal nerve stimulation has been used for the treatment of a wide range of conditions, including seizure, depression, heart failure, and other systemic disorders. VNS was approved for chronic treatment-resistant depression a long time ago, 2005. I didn't realize that. Additional applications are also under development as a treatment of heart failure and treatment of drug-refractory rheumatoid arthritis, of all things. Wow. Additional applications, including the treatment of headache, obesity, asthma, and movement disorders, are also under development. The exact mechanism of action of VNS is unknown. It's believed that stimulation of vagal nerve afferent fibers, the largest component of the vagus nerve, electrically suppress neuronal activity in a wide distribution of brain areas and modulate neurochemicals, including serotonin and GABA. The VNS system consists of a subcutaneous pulse generator, which lies in the left infraclavicular region, and two leads, which are tunneled to the vagus nerve in the lower neck. The leads connect to thin ribbon electrodes that are held in contact with the vagus nerve by plastic or metal helices, which encircle the nerve. Although there have been reports of successful seizure control with right VNS, the left vagus nerve is generally used, as stimulation of the right vagus nerve carries the risk of bradycardia owing to sinoatrial node stimulation. On frontal radiographs, the VNS pulse generator lies in the left infraclavicular region, and the leads extend to the left aspect of the lower cervical spine. Two small metallic ribbons, one superior to the other, represent the negative and positive electrodes. On lateral radiographs, the distal wire has a sinusoidal configuration to act as a string leaf when the head is turned to the side. Wound infection and hematoma is uncommon and may be detectable at ultrasound or CT. Post-implantation pneumothorax has been reported, but I'm sure it's extremely rare. Loss of device efficacy may be due to device malfunction or end of battery life. but it may also be caused by lead or electrode breakage or displacement. Lead and/or electrode breakage or displacement is routinely evaluated on radiographs. Spinal cord stimulators. These have grown wildly popular, and they're used to treat a wide variety of chronic pain conditions, most commonly chronic back and limb pain, including failed back surgery syndrome, complex regional pain syndrome, and chronic limb pain owing to painful peripheral neuropathy, all of which are FDA-approved indications. Additional off-label indications include refractory angina, abdominal pain, and peripheral vascular disease. When placing an SCS system, the electrodes are placed adjacent to the dorsal columns, which conduct touch and proprioception information to the brain. The mechanism of action was originally explained by the gate control theory, whereby stimulation of sensory signals in the dorsal columns activates inhibitory interneurons in the dorsal horn, which blocks the transmission of pain signals through the shared gate. However, additional mechanisms are currently thought to play a role, including action on neurochemical signaling systems, effects on the brain, and modulation of end-organ blood flow. A patient typically undergoes an initial trial with temporary externalized leads to determine if he or she experiences meaningful pain relief. If so, then a permanent system is implanted. The SCS system consists of an implantable pulse generator, epidural electrodes placed at the required level, and leads connecting the generator to the electrodes. The electrodes are placed using fluoroscopic guidance, and routine additional post-procedure imaging is usually not necessary. If imaging is obtained for other reasons, the pulse generator should be depicted in a subcutaneous location, usually in the flank, abdomen, upper buttock, or paraspinal region. Continuous leads should be depicted extending from the pulse generator into the posterior epidural space, where paddle or cylindrical electrodes are visualized at the lead tips. On the lateral view, the electrodes should be located in the posterior third of the spinal canal. The most common complications of SCS are related to device malfunction, which requires reprogramming, or lead and/or electrode displacement or breakage, which are best assessed at radiography rather than CT. Electrode migration is more common with percutaneously placed cylindrical electrodes, but may also occur with surgically placed paddle electrodes. The most common biologic complications are infection, fluid collection, or wound dehiscence. Clinical information such as pain, purulent drainage, fever, and fluid aspiration will help in determining whether a fluid collection about the pulse generator or lead is due to seroma, hematoma, or abscess. Imaging can help assess the extent and depth of involvement. The most serious complications are uncommon. These include cerebrospinal fluid leak owing to accidental dural puncture during lead placement, traumatic neurologic injury during lead placement, and epidural hematoma or abscess. If severe pain, developing weakness, or paralysis is manifest, the diagnosis of epidural abscess or hematoma should be considered. Performing CT or MRI is required for diagnosis. So there's so much in this great article. They also talk about cardiac devices, diaphragmatic stimulation, gastric stimulation, and sacral stimulation. For all of them, the common complications diagnosed at imaging include infection, hematoma, lead migration, and lead breakage. Understanding the components, normal function, and normal imaging appearance of each device allows the radiologist to identify complications. Now, in terms of MRI safety, which is another topic for another day, understanding how biomedical implants and devices impact patient safety is critical for radiologists and technologists. Improper patient screening for these items can result in serious consequences, including tissue damage, burns, unintended stimulation, or death. The electromagnetic fields used for MRI can create problems with patients with metallic implants that primarily include movement or dislodgement if the items are ferromagnetic, and excessive heating if the objects are located within the area of the transmitted RF energy. Certain implants, such as those with electronic components, referred to as active implantable medical devices, can also be impacted by RF-inducing heating, as well as induced electrical currents. The functional or operational aspects of some implants may be altered, or the devices can be temporarily or permanently damaged as a result of exposure to certain MRI conditions. Medical implants generally fall into two categories: passive, which includes vascular clips, heart valve prostheses, shunt valves, and orthopedic implants, and active, which consist of cardiac pacemakers and neuromodulation systems with electronic components. For active implants, Concerns may include unintended stimulation associated with the time-varying gradient magnetic fields and the potential malfunction of the device due to interaction of the electromagnetic field. As a review, in May 2021, the FDA released a new guidance document, Testing and Labeling Medical Devices for Safety in the Magnetic Resonance Environment, which explains the terminology identifying medical items that can and cannot be permitted in the MRI environment. Accordingly, all implants and devices must be labeled as MRI safe, conditional, or unsafe. The term MRI safe refers to items that pose no known hazards in all MRI imaging environments. These are non-conducting, non-metallic, and non-magnetic items, such as standard Foley catheters and monopressure cerebrospinal fluid shunts. These are made from silicone or plastic. An item may be determined to be safe by providing a scientifically based rationale rather than test data. The term MR conditional refers to items that have been demonstrated to pose no known hazards in specified MRI environments with specified conditions of use. These can include orthopedic implants, heart valve prostheses, bone fusion stimulators, programmable infusion pumps, and cardiac devices. Active devices such as cardiac pacemakers and neuromodulation systems like we've been talking about have highly specific MR conditional guidelines that must be carefully followed to ensure patient safety. For example, there may be conditions specified for a particular implant placement configuration or for special programming before and after the MR exam that must be followed. Okay, I better stop there. A long podcast this week, but there's so much information to share. Take a look at these articles on the website. You have to see the images. And watch for cases on Twitter. Join in with us and learn. Thanks for listening, and we'll be back in 2 weeks with more summaries.